If antibiotic treatment of non-tuberculous Mycobacteria, or NTM, lung disease is indicated, prescribed therapy is generally directed against the specific NTM species identified and their drug susceptibilities. Regimens are always multi-agent, with many of the commonly employed antibiotics not specifically FDA approved for NTM lung disease. Linezolid, clarithromycin, and azithromycin inhibit RNA-dependent protein synthesis by binding to the 23S ribosomal RNA, or rRNA, position of the 50S subunit of the bacterial ribosome. Assembly of the ribosomal complex needed to initiate messenger RNA, or mRNA, translation is impeded, thereby halting bacterial growth. Tigecycline also inhibits bacterial protein translation, but this time through binding at the 30S ribosomal subunit. Transfer RNA, or tRNA, is subsequently blocked from entering the bacterial ribosome, preventing the addition of amino acid residues to a lengthening polypeptide chain, and bacterial growth is halted. Moxifloxacin inhibits topoisomerase II, or DNA gyrase, and topoisomerase IV, responsible for separating DNA tangles, relaxing positive supercoils, and, in the case of DNA gyrase, introducing supercoils into DNA. Inhibition results in the prevention of bacterial DNA repair, transcription, and replication. Cefoxitin inhibits transpeptidase, an enzyme that cross-links peptidoglycan molecules within bacterial cell walls. This aids in bacterial destruction through cell wall weakening, leading to susceptibility by lysis. Ethambutol and bedaquiline interfere with mycobacterial cell metabolism. Ethambutol inhibits metabolite synthesis, and bedaquiline inhibits ATP synthase. There is an impairment of cell energy generation and metabolism, preventing cell replication, leading to cell death. Clofazimine and rifampicin inhibit mycobacterial growth. While the precise mechanism of action of clofazimine is unknown, rifampicin inhibits bacterial RNA polymerase, or RNAP, and interferes with RNA synthesis by blocking the developing RNA transcript from elongating. Amikacin binds to the bacterial ribosome and inhibits protein synthesis. Inhalation of amikacin liposome, a newer formulation of amikacin enveloped in liposomes, provides direct delivery into the lungs via nebulized inhalation, where the liposome is taken in by circulating macrophages. This agent then binds to the bacterial cell wall, disrupting its architecture. Protein synthesis is inhibited by agent binding at the 30S ribosomal subunit, subsequently blocking tRNA ribosomal binding. Amikacin inhalation has specified approval for use as salvage therapy in patients with refractory MAC lung disease. Mycobacteria can generate biofilms, a matrix of extracellular polysaccharides, lipids, and nucleic acids, to form a protective structure that helps bacteria resist high concentrations of antimicrobial agents. Amikacin inhalation's lipid-soluble liposome can penetrate the biofilm complex to deliver higher concentrations of the antimicrobial agent at infection sites. The goal of therapy in NTM lung disease is to achieve 12 months of negative sputum cultures during therapy administration. Frequent culturing, up to every 1 to 2 months, may be necessary to assess the therapeutic response appropriately.